Good afternoon. Hello and welcome to the second presentation of the UWI Mona Western Jamaica Campus Research Seminar Series. I am Alpha Obika, a coordinator at the Caribbean School of Media and Communication here at WJC. And I'm proud to be a part of this initiative of the campus director, Professor Donovan Campbell. The Research Seminar Series is an activity geared toward providing a platform for faculty, students, academics, members of the public in the wider community to share their knowledge, ideas, and research. The presenter today is Mrs. Veronica War-Brown. She has a Master of Public Health, majoring in health education and health promotion, and is a doctoral candidate. She's a registered nurse, a registered midwife, family nurse practitioner, nurse educator, and health education and promotion specialist. She is a lecturer and coordinator of the BSc in nursing here at the UWI Western Jamaica campus as part of the School of Nursing. Her research interest is on chronic non-communicable diseases, particularly hypertension and cancers. Today, she will present a research entitled An Evaluation of the Management of Hypertension in Primary Healthcare Facilities in Western Jamaica. This is an important topic, and we are indeed blessed to have the wealth of knowledge and expertise that you will hear today. Please join me in welcoming Mrs. Veronica War-Brown.
Thank you, Dr. Obiko, and a pleasant good afternoon to all my listeners and viewers. It is indeed my pleasure to be here with you this afternoon to share with you a research proposal looking at an evaluation of the management of hypertension in primary healthcare facilities in Western Jamaica. So to begin with, I want to make you aware of what actually piqued my interest in the field of hypertension. Well, my mother, she lived with hypertension for many years. As much as I knew her, she was living with hypertension. And the sad thing is that her blood pressure was not controlled for the most part. And sad to say, she eventually died from complications due to the uncontrolled hypertension. In addition, years ago, I worked in the parish of Hanover as a family nurse practitioner, and one of my responsibility was to coordinate the non-communicable disease program in the parish. And among those non-communicable diseases, diabetes and hypertension topped the list. When I looked at the fanfare, as I would call it, that we had for diabetes on World Diabetes Day, I said to myself, but from the figures I'm seeing, we have more patients with hypertension, and there is not so much emphasis when it comes to World Hypertension Day. So as a result, I developed an even greater interest in hypertension. Why this concern with health system related factors? When I studied for my master's in public health, I looked at factors affecting patients who had hypertension. And this is a condition that is well studied, the patient-related factors. However, we find that there is a relative sparsity of information or studies as it relates to those factors that concern the health system or the health delivery system. So today, what I'll be presenting basically is a background Thank you. That's what happened when we are vertically, they say, challenged. Okay. All right, thank you so much. So, for today, we'll be looking at basically the literature review as it relates to hypertension and its control, the profile of the Western Regional Health Authority as it relates to the delivery of care for patients living with hypertension. So I'll be looking at the literature, looking at the data found in the Western region primary healthcare delivery system, the theoretical framework to my study, the significance of the study, as well as how I will go about to conduct the study. So as you realize, this is not a study that has been conducted already. The groundwork is not there. So I'll be walking you through what I will be doing in carrying out the study. So let's look at the background. Hypertension is the leading cause of medical consultations within primary healthcare facility. What do we mean by that? When you look at all the different conditions that patients go to the primary healthcare facility for, hypertension tops the list. And how patients are managed within primary healthcare, or how the condition is managed, definitely will influence the outcome of the client. Now, hypertension is primarily a lifestyle disease, and it has a significant genetic component, but what we find happening is that even though it is familial, it runs in families, we find that hypertension can be prevented and it can be controlled because by and large, it is a lifestyle problem. What we find, based on the Hypertension League and the International Society of Hypertension, when you look at the studies, hypertension is ranked as the leading risk factor for morbidity and mortality. So we find that hypertension-related conditions are making many of our population coming down with conditions that causes them not to be able to function at their maximum, and it's causing many persons to die as a result of the condition. The other thing that we need to pay attention to is that hypertension is not just affecting a couple of persons. The prevalence is high. And the high prevalence also show that many persons have the condition, but when you look at how controlled are these persons, the control rate is unfortunately low. So we find that hypertension is a major public health challenge. It is a problem, and in some literature, it is being referred to as a chronic pandemic. So just to help us to be on the same page as to what we're talking about when we talk about hypertension, hypertension is defined as the sustained elevation of blood pressure above 139 systolic. So when we talk about hypertension, it is measured with two readings, a systolic reading and a diastolic reading. So for a person to be diagnosed with hypertension, there's a sustained elevation of the blood pressure, systolic, the top number, 139 millimeters of mercury, and the bottom number above 89. In the literature, you might see it greater than 140/90. Basically, it's saying the same thing. And this is in reference to our adolescent and adult population. Hypertension is classified as prehypertension, stage 1 and stage 2 hypertension. Prehypertension means that the person is not yet diagnosed with hypertension, but is at high risk for developing hypertension. And what the JNC 7 guideline shows is that we have a large population who are pre-hypertensive, so we find that if we are not careful, those persons who are pre-hypertensive will become hypertensive patients as well. So having that understanding, hypertension is of concern. It is regarded as the silent killer. And why so? Because many persons who have hypertension are not diagnosed. So many persons, probably some persons in this very room, do have hypertension, but are not yet diagnosed. And because it is asymptomatic, for the most part, the silent killer, many persons are diagnosed just at the point when they have developed what we call target organ damage, meaning they might realize that they have a stroke or they have a heart attack or something that takes them to the doctor. But other than that, they may be going around with it for years and years not knowing what is happening. And because of this, hypertension carries a high rate of morbidity and mortality. Now, it is important to have high blood pressure under control. And the reason being, when we look at the burden of the disease, it means that it is affecting the individual, it's himself or herself. And if you should look at the diagram to my right, to your right as well, you will see that uncontrolled hypertension contributes to heart disease, coronary heart disease. So people can get heart attack as a result of uncontrolled hypertension. Also, the hypertension can damage blood vessels within the brain or cause clots within the brain, leading to stroke. It affects the kidney, leading to renal impairment, and the cost for dialysis, I would say, is prohibitive for many of our population who are diagnosed with hypertension. It affects the eyes, causing visual impairment. It affects also the blood vessels. So we find by and large that the quality of life of persons with uncontrolled hypertension is in jeopardy as long as they remain uncontrolled. And if that's not hard to grasp, think about the effect that it can have on the families. Think about the effect that it has on the healthcare system, bearing in mind that I said earlier that it is the leading cause for visits to medical clinics within the primary healthcare system. And then looking at the larger picture, we want to think of the impact it has on the economy. The global picture shows that hypertension is ranked second place among the conditions that contribute to global burden of disease. And the World Health Organization in 2024, this very year, shows that 12.5% of deaths worldwide occurs as a result of uncontrolled hypertension. And there are 57 million persons living with hypertension who are not able to function to their maximal potential because of uncontrolled hypertension. So we see that the cost of illness is significant. And Frey, Akins et al. In 2016 conducted a study here in Jamaica looking at the cost of illness as it relates to non-communicable diseases. And it was found that hypertension topped the list. It was among the three top main contributors to the burden of the disease in Jamaica. And the World Health Organization looks at us investing in primary health care to reduce this economic burden that hypertension creates. So if we get persons living with hypertension having their blood pressure under control, then it would mean that the individual is going to have improved quality of life. There will be a decrease in the demand on families as well as the healthcare system, and we'll find that our economy will also benefit because there's going to be increased productivity and a reduction in the burden of the disease. So, we want to talk a little about the prevalence of hypertension. And what we're seeing here is that Kearney et al. In 2005 reported that in the year 2000, globally, the world population living with hypertension, it was 26.4%. Brooks in 2005 predicted that by 2025, there would be 33% of the world's population affected by hypertension. However, the World Health Report of 2013 reported that there was a 40% of the global population living with hypertension. Interestingly, in 2023, the World Health Organization published that there were 33% of the world's population living with hypertension. And what the literature shows is that there has been some improvement in the developed country as it relates to hypertension prevalence, but the middle and low income countries are still grappling with dealing with the scourge of this condition. As mentioned earlier when we looked at these stages of hypertension, I spoke about the pre-hypertensive stage. The World Health Organization also has reported that as much as 46% of adults worldwide are living with hypertension and they are not aware of their situation. The Jamaica Health and Lifestyle Survey 3, which was conducted between 2016 and 2017, showed that 33.8% of Jamaicans 15 to 74 years old are living with hypertension. These are diagnosed cases. And as much as 34% are living in a pre-hypertensive stage. So we can see that the prevalence of hypertension is quite high, and it is time that we take more serious look at how we can do things better to control those persons living with hypertension and prevent those who do not have hypertension from getting the condition. So I want for us to look at the Jamaican picture. And there is a 30-30-30 slogan that the Ministry of Health looked at, where in 2008 there was 30% of adults 30 years and older living with hypertension, and only a 30% of that population was controlled. We find that the global picture where the highest frequency of visit for hypertension to medical clinic is for hypertension. There's a similar pattern in Jamaica where in our setting at our primary health care facilities, the medical clinics are seeing persons living with hypertension having the highest frequency of visits. And at the same time, the rate of control is significantly low. Within the Western region, and this is where my study the setting for my study, looking at the Western Regional Health Authority, the region, each health center has a hypertension register, and that is fed into the regional register. In 2009, there were 9,106 persons on the registered diagnosed with hypertension. In 2017, there was an exponential increase where the figure on register was 16,635, an 82.7% increase. And you may say to yourself, but that could not be so. And what we find, or what we saw happening at that time in 2009, that was when the government introduced the free health, no user fee into the system. So what happened? There was an influx of persons utilizing the primary health care setting for management of their hypertension. So that accounts for that increase. But regardless of that, we find that the number of persons on register continue to increase. Also, we find that during 2014 to 2018, the percentage of visit to medical clinics was as much as 26% of all the curative visits to the health centers. And the rate of control, looking at the Western region, previously I mentioned at 30%. This is the latest data for 2023, where the average control is now 40%, and we can say we seem to be doing something right in the Western region, where we have seen some improvement in the rate of control. But when you look at 40%, still there is a 60% that is not controlled, and that is not good. Now, in previous years, the Ministry of Health and Wellness service level agreement for control of patients with hypertension, the target was 58.7%. But because it was an unrealistic figure, it is now dropped to 40%. So we find that in the Western region, we are meeting up with the Ministry of Health and Wellness SLA target for control. But that's no reason for comfort. Hypertension is largely managed in our primary healthcare setting. And we find that if 60 to 70% of our hypertensive population remain uncontrolled, it means that we need to look more closely at what is happening in the healthcare delivery system. Now, we can't blame everything on the healthcare delivery system why patients' blood pressure might not be controlled. However, as the healthcare delivery system sets the pace or influences the kind of care that patients get, it is not too much to say that we set the standard, or the health delivery system sets the standard for control. When we talk about patient-related factors that influence control, yes, the patient has their responsibility as it relates to health literacy, their attitude towards their condition, their personal behavior, and their health belief, right? Because there are still those persons who think that if they boil a bush and do something, they are all right. So we have to consider all of that. But as the healthcare delivery system, we now have that responsibility to educate our patients and to guide them towards healthy lifestyle practices. So we want to look now at, or this study wants to look at the health system related factors as it relates to how well are we doing in terms of service delivery? How well are we doing in terms of human resources in the healthcare provider-patient relationship? Because there are patients who will say they're afraid to talk to their healthcare provider, or from the sit down, the healthcare provider starts writing, and there's not that kind of a relationship. And we also want to look at what are the infrastructures in place that promote control of our patients with hypertension. So the onus, or the greater onus, lie with the healthcare provider. So the healthcare system, primary healthcare, holds the key to prevention and control, as our patient is dependent on the healthcare system to provide them with the necessary guidance. Hence, this focus on the healthcare delivery system. Now, what is the role of the healthcare delivery system? It acts as the bedrock for achieving prevention and control for a wide spectrum of health-related conditions. And the concept of a holistic approach to health and well-being, and it addresses the broader determinants of health. Now, the key to controlling hypertension lies in the quality of care that the patient receives through primary health care delivery. The current modus operandi of the management of hypertension in our primary healthcare setting is predominantly doctor-centric. And New Payne in 2021 looked at a study, well, he did a study and concluded that the overwhelming workload of our primary care doctors could be a possible deterrent in them providing comprehensive care to patients. And this correlates with the poor patient compliance, hence poor control of blood pressure. So as part of the study, I want to look at can task sharing and task shifting intervention help to mitigate some of these problems. And with all that in mind, the 60 to 70% of patients who are not yet controlled, hypertension accounting for the greatest proportion of visits to medical clinics in the primary healthcare setting, hypertension being the leading cause of morbidity and mortality, the low rate of control actually is pointing to an indictment on the healthcare delivery system. And studies have shown that the healthcare delivery system, there are not enough studies to support whether or not the healthcare delivery system is doing what it is supposed to do. And there are definitely weaknesses and strengths to the system. So a study like this evaluating the management of hypertension is necessary, hence the reason for this study. So what is the significance of this study? From this study, it is hoped that the findings will lend support for future action research studies. It is also hoped that with the future action research studies, there may be the implementation of task sharing, task shifting interventions where more time can be spent with our patients to guide them towards healthy lifestyle choices and practices that will ultimately lead to a reduction in the morbidity and mortality associated with uncontrolled hypertension. And it will also help to guide the Ministry of Health and Wellness in utilizing the findings in their planning and policy regarding the management of hypertension in primary healthcare settings. So for this study, the conceptual framework that will be utilized is the Dunabedian quality of care model. And this model has been a useful benchmark for evaluating the quality of healthcare worldwide. It's a commonly used framework. And it measures three distinct aspects of quality. It looks at the structure, the process, and the outcome. This structure has to do with the physical and organizational aspect of care planning and includes the provider's capacity, the system and processes to provide high quality care. When we talk about the process, we are looking at what the provider does to maintain and improve the health of the patient and reflects accepted guidelines for clinical practice, as well as it impacted on structures. It impacts on structures in the delivery of patient care. What's the outcome? That's the end product of the quality of care that is provided to the client. So here we are looking at utilization for the study. I'll be looking at the human resource. Do we have enough doctors, nurses, nutritionists, all of those persons in place to help in the care? What's the waiting time that patients have at the clinics? Is the clinic patient friendly? The processes, the patient provider relationship, follow-up appointments, outcome, are patients adhering to the treatment, what is their control level, and are patients satisfied with their care. So the study aimed to assess the efficiency and the primary care in the management of patients with hypertension in Western Jamaica. And there are 5 objectives that will guide this study that will examine the structure, processes, and outcome of care that is given. I'll be comparing the management with what is best practice to what is actually being practiced in the field, and look at associations between what is the current management and the outcome of the patient, as well as exploring the possibility of nurses taking on lead role in hypertensive-led clinics for better control. So in terms of methods and material, I will be looking at a multi-method approach, not a mixed method because I will not be integrating the findings. So it's a multi-methods approach in which there will be 2 surveys. One survey will be geared towards the healthcare provider and how they see the management of patients with hypertension. The other survey will be targeting the patients themselves with hypertension who visit these centers. I'll also hope to conduct a docket audit to look at over the years how have patients been managed, and a focus group discussion to see how persons perceive a nurse-led clinic intervention. So the setting is the Western Region Health Authority medical clinics, and I will be focusing on those clinics that conducts medical, those health centers that conduct medical clinics. That's your type 3 to type 5 health centers. And based on the number of patients on the register, it will determine my sample size. So for the healthcare provider, I'll be doing a census, and the sample size will be calculated for those participating as patients. So in the survey that is targeted towards our patients, the participants will be selected through simple random sampling, and this will be proportional to the total on the parish register. All right, and this is how the sampling of the health centers will be done. So based on the type of health center, type 1 health center in the Western region do conduct medical clinics. So we will have, I will be sampling from type 1, type 2, type 3, type 4, and type 5 health centers. All right, so for the questionnaires that will be used in the survey targeting our healthcare providers, this will be pre-tested in a different region. There will be close-ended questions, and based on the response, it will be modified accordingly. For the data collection tool, for the docket audit, the Ministry of Health has an audit instrument that will be used with their permission, and selected number of dockets from each health center will be audited. I will be validating the questionnaire through content validity, pre-testing, and clarity will be sought as the pre-tested questionnaires will seek clarity in another region and modified as necessary. Research assistants will be trained to assist in the collection of data, and the data will be collected on the days in which the medical clinics are in operation. And patients will be instructed that they can participate voluntarily. Their information will be held confidentially, and it will be kept in a locked cabinet. SPSS software will be used to analyze the quantitative data, and the qualitative data will be analyzed manually. Right? Ethical considerations are taken as to permission will be sought to conduct this study. There will be voluntary informed consent, anonymity, and only information relevant to this study will be utilized. All right, so I think I'm out of time, so I will take your questions, your comments, and I want to thank you for being a very good audience.
Please give her a round of applause. We have about 10 minutes, so while we allow her to have a sip of water and catch her breath, this topic is relevant to all of us. Many of us know somebody in our own families, even ourselves. Many of us suspect that we need to get tested, because even if you think you're healthy, we might fall into that hypertensive, yes, nearly good to say pre-diabetic. I fall into that myself. All right, so questions. I will be moving around with the microphone, so feel free to raise your hands, and let's get the show on the road. I know that we have, I neglected to say, a number of healthcare professionals, colleagues, so I do hope to hear from some of you, because I know that you will have lots of questions. So, Prof?
Thank you very much for a very interesting presentation. I was glued to your presentation. I really enjoyed it. I have a whole heap of questions. Some of them I will take to you personally. But in your assessment of the data for the Western region and Jamaica as a whole, are you seeing any sort of socio-demographic trends or patterns? Are there particular groups of people that you think are showing up as more predisposed? Is there any disparity in terms of wealth, for example, or gender, for example? Yeah?
All right, I will answer that based on my previous study that looked at factors influencing the patient-related factors. And from that study, coming out, smoking was one of the factors. Obesity is in the literature. I'm not sure if I should say fortunately or unfortunately. The study I did, obesity was not one of the standout factors, but yes, many other studies have identified obesity as a factor. Also, in terms of age, we find that, and that is understandable, the older you get, the more at risk you are for all of the chronic illnesses. But also interestingly, the literature shows that there is a trend towards younger persons coming down with hypertension. And this whole drift in lifestyle practices. So we don't cook on a Friday. Some persons, it's just one day per week they cook at home now. So we go to the KFC and we go to all these fast food places and we eat. And we find that we have more of a sedentary lifestyle. No longer children play dandy shandy and hopscotch and that kind of thing. So we find them at the computer sitting down If they need to talk to somebody in the next room, they pick up the phone and they call, they don't walk across. So we find that this lifestyle that we have so liked and hug and think it's the best for us, it's actually killing us. So those are some things that stand out.
Any other questions?
I should also share too that it was shown from my study that persons who are married are at increased risk for hypertension. I am not telling you don't get married though. So that calls for another study. That calls for another study to say, are married people more stressed than those who are not married?
Good afternoon, everyone. Thank you for a very informative presentation, Mrs. Warbrown, representing Nursing Well. Congratulations on what you have done so far. I have a question about your methodology. You said it was a
Multi-method.
multi-method, all right. Do you need to do so many methods? That's my first question. And the other question I have is, you did say you want to do a focus group about the nurse-led initiative. Who's your target audience, your target population for that particular, is it the consumers of the product, or is it us, the workers?
It's the healthcare providers.
Oh, okay. And that would be across, is it nursing only?
Not only nursing, nurses, doctors.
Okay, all right. That should be interesting to hear the point of view about a nurse-led initiative. Thank you.
Thank you too.
All right. Do you care to respond about the number of methods?
Okay. Yes. I know that it's a lot of work. Yeah. It's a lot of work. The two surveys, I think it warrants both, because I'd really want to see the perspective from the healthcare provider, and I'd also want to look at the perspective of the recipient, the patient living with hypertension. Doing that evaluation, it would be getting both sides of the picture. So I can say, well, the healthcare provider might be short-sighted when it comes to some things because the recipients are not seeing it that way. So I do think I need both survey. The docket audit also will strengthen, because doing a survey, you can say one thing, and when you look in the docket, it's something else. So it will strengthen the findings. The one that I toyed with in my mind is the focus group discussion. Well, if I also want to find out if this would be a good initiative. Because yes, I'm evaluating the management, but in evaluating the management, do I have a suggestion? Do I have any recommendation after evaluating the program to say nurses stand ready to lead out? And the literature shows that places that have implemented nurse-led clinics, the outcome is better. So if I can get that in, it will strengthen the argument to say, well, these are the deficiencies in our current healthcare delivery system, and they're based on what has happened in other places. They are having successes doing XYZ, and our nurses stand ready to take on this responsibility I think it would also help the study. So whilst it's a lot of work, I do think they're all relevant.
Excellent, excellent. And we have time for 2 more questions.
Thank you very much for a very informative presentation. I'm sorry I missed the beginning, but I just wanted to ask if you had considered at all the chronic care model as a framework for looking at all the different aspects of service delivery, healthcare delivery that impact hypertension. So that was one question. And I think the other one was, you had mentioned reviewing dockets or reviewing files or something, no? Reviewing dockets? Right, and I just wanted to know if there was some kind of guide that gives you some indication of what the review would look like so it could be consistent across all the different files. And the third point was about, I got the microphone, I'm just going to take it while I can. The other point was about looking into qualitative software as opposed to manual, save some time, and really good at just helping you along the process. Thanks.
Thank you so much for all those questions. I do appreciate them. Yes, I've looked at the chronic care model, and it has its worth. I've also looked at the HARTS, H-A-R-T-S, that PAHO is pushing now, that is showing significant benefit to those countries that's utilizing it. So that's something that we could adopt here as well. Your second question has to do with the docket audit. And the Ministry of Health and Wellness, they have an audit tool, right? And based on their audit tool and with their permission, I will be using that as a guide. And your third question to do with the software. Well, I'm sending out an appeal. I don't know how to use the software. So for those persons who are au fait with the software, I am okay. Thank you so much. All right. So I'll be coming to you. Okay.
All right, I think we have time for one more question. I know Prof, you had a lot of questions. I can give you the last word, director's privilege.
All right, thanks. You mentioned something about health literacy, and it piqued my interest because I think there needs to be, another, not necessarily another study, but this needs to be looked at in detail, because maybe that's one of the driving factors, how much people know, for example, about what they're eating, and just that black box there. I want to understand a little bit. You mentioned the structure and processes that you'll be following. To what extent do you see medical innovations and technologies, as part of the solution to this big problem we face? How can we use modern technology to get more information to the population, so that people become more aware and we tackle that health literacy challenge? So I want to, from a hypertension standpoint, to see if you're thinking about what sort of innovations. I know we have Health Connect here, and maybe that could be an inspiration for a possible solution as to how we can reach a wider population, so as to improve the literacy among the population in terms of health. But just, your perspectives on innovations that can help to tackle the problem.
And I thank you for that question, because when I'm thinking of a nurse-led clinic, I'm thinking of something that would include modern technology. So there would be a connection, not with using technology to interface with the client in their home setting, right? So based on I have this number of persons in my clinic, how do I reach them? How do I help them to maintain a healthy lifestyle? Because when we think about it, if you have bad habits from day one, it's going to be hard to change. And even when you do change, the smoker will tell you that, yes, I stopped smoking, but there are times when I am tempted to smoke again. So if we have a nurse-led clinic where persons can be supported in healthy lifestyle practices, with the use of technology and with sharing, say, for example, you measure your blood pressure at home, you can send us the reading of the blood pressure. We can guide you as to what to do. Do you need to come in now? Do you need to adjust something? So yes, definitely that's been a part of my thoughts. And this is where I think from this, the findings of this study, action research would put it together as to all that we'll need to implement in that nurse-led clinic. So I want to thank you all for joining in, for participating, and I look forward to the next seminar. And I do look forward to sharing the findings of this study with you, and I do hope that it will benefit not just one or two persons, but the entire Jamaica population. Thank you much.
Ladies and gentlemen, let's give her another round of applause for an excellent presentation. We look forward to the findings, and I hope when the findings come out, Mrs. Ward-Brown, that the married people have a better chance, right? Because that statistic is kind of frightening. Anyhow, just to say that we're doing excellent research here at the UWI Mona Western Jamaica campus, and I must congratulate our colleague. We look forward to the findings and another presentation when the results are out. And also, best of luck with your studies as well. So tune in next 2 weeks. It's Thursday, November 28th, where we will have the final presentation for this semester. I will be presenting, so I'm really excited about that. And I know that the communication will come out. I want to, on behalf of the Office of the Campus Director and his hard-working team who have provided this platform, I want to thank you for being a wonderful audience, and I also know we have persons online who have joined us for this seminar series. Thank you and have a wonderful day.